send out a link to
This meeting is being
after the meeting. Perfect. All right, next slide. I'm going to ask all of you who have joined today to help me get to know you by putting in the chat your name, your organization, and if you do ECM, community supports, or both. And then, of course, we always have a great icebreaker, as we do with every CPI. So want to know what your favorite game is to play. So if you could put that in the chat, that would be fabulous. I love Boggle. That is my favorite game. Or Clue. For those who know Clue. All right, Toby, what's your favorite game? Oh, there we go. You entered a Monopoly. All right. Now, do you do the old-fashioned Monopoly, or do you use one of the newer versions of Monopoly? Backgammon. Okay, I see Amber, you like Taboo. Oh, great. Oh, Toby, you like the original Monopoly. Okay, great. All right, Uno, very nice. We'll keep it coming. Your name, organization, ECM, CS, or both, and then what your favorite game is to play. All right. So we are going to have hopefully an engaging session today. I would love to have you all participate and ask questions and share your thoughts. So I encourage all of you, if you would like to jump in, to raise your hand, come off mute. That would be fabulous. And then if you want to use the chat to ask questions, feel free to go ahead and do that as well. All right. Next slide, please. So you all are familiar with the slide. You've seen it before. Our favorite Jimmy is here helping us with this. But just do a real welcome to all of you here today. Do we have anybody who's new to the CPI besides me? Anybody brave enough to raise their hand? Okay, if you are new, if you would love to come off mute and introduce yourself, that would be fabulous. If not, you can put your name in the chat and let us know that you are new to the collaborative. And we welcome you here today. This is really a space that's been designed to have stakeholders really engage with each other as we all implement ECM and community supports. Our goal is here to work together to really make these programs successful and to support all of us as we figure out what are the obstacles and how do we overcome them to these programs. We do save all materials and make them public. They will be in the folder listed here today. I know you all have access. If you have any issues, please let us know. All right, next slide, please. And if, I don't know if you want to jump in on this slide, or Sadhana, I see you're here as well.
Yeah, I'm happy to jump in unless Sadhana would like to.
You can go ahead, Ava, and I can fill in anything.
Okay, yeah, we just wanted to let everyone know, I'm sure some of you are aware that Alexis Taylor is no longer on our Health Begins Medi-Cal transformation team. And so we just wanted to let you all know that I will now be, I've sort of been the point of contact for this collaborative, but I'll be the kind of sole point of contact in case you're trying to get in touch with her. But we just wanted to take a moment to, just let everyone know and take a moment also of gratitude just for the amazing work that she did for this collaborative.
Yeah, and I think the only thing I would add is that luckily Alexis is not going too far. She'll be overseeing the LA collaborative. So just in a different region, continuing the great work and thought leadership that she was able to do here. So just really excited for that new opportunity, as well as for our growing team here.
Great, next slide, please.
So we just want to touch on the objectives for today's session. As always, we will start off with making sure that everyone receives updates and resources, and then we'll move into finalizing and making sure this group really understands our 2024 regional goals and associated measures. And then really the bulk of our conversation today will be devoted to discussing regional provider referral coordination. Next slide, please. And then just to sort of map out how the session is going to go, After we go over updates and resource sharing, we'll have that referral coordination conversation. We'll touch on aims and measures. We'll really want to hear from you all about your best and worst referral experiences. We'll touch on untapped resources and information gaps. And then we will, as always, touch on next steps and what to look forward to in the collaborative. Next slide, please. So as we've mentioned before, we're hoping to host a couple of in-person sessions. We're aiming for late June. And right now we're thinking, as we mentioned before, we want to make sure that we expand to different locations within the Northeast. So right now we're thinking we'll do a session in Shasta and then maybe one in Lassen, Modoc, or Trinity. But we really want to hear from you and see, if anyone here is interested in hosting one of these sessions. We would, do all of the heavy lifting, the legwork, handle all of the coordination and logistics. But if you would love to be involved in bringing the collaborative to your county, we would love to hear from you and can follow up with you on the back end. So let me just launch this poll. Just take a second to let us know if you're interested. And I'll follow up with anyone who is. Or if you decide later on you're interested as well, please feel free to email me. I'll give it just another minute. All right, I'll go ahead and end that. Thank you for everyone who responded to that. And then next slide, please. And now I will pass it over to Gretchen for updates and resources.
All right, thanks, Ava. So there weren't a lot of DHCS updates for us to share this month. It's surprisingly been a kind of a slow month with policy updates, but we do have some other resources we wanted to share with you. First up is that we did just get the most recent data report from the state for ECM and community supports. It's looking at how implementation is going. And this is really a comprehensive data dump. There's a lot of great information in here. It does let us know how many folks are enrolled in each population of focus, how many providers there are. Unfortunately, this data is a little bit old. It is from September 30th of 2023, so a little bit delayed, but it is still interesting to the trends that we're seeing with enrollment. One of the big things that we've seen is that when ECM and community supports first started, we had a lot of folks who transitioned from whole person care into these new programs. So we had a high number of enrollees. And then, of course, as those folks graduated out, we started to see the enrollment decline, but now it's starting to come back up again. So it's, a lot of work still ahead for us, but I think it is showing some positive trends in that regard. And I don't know if anybody else has seen this report and read it and wants to share any details. There's a lot of information in here. All right, let's go to the next slide then, please. So something that I'm very excited to share with you guys, because I love finance and budget. That's my favorite thing to talk about, is our friends at the Camden Coalition, who are also facilitators of other CPIs across the state. They have put together a really helpful budget estimator tool for ECM and community supports. It's helping all of us figure out what does it take in terms of rates, in terms of caseloads, for all of us to be financially sustainable doing these programs. And I think it's a great tool for folks who are considering ECM or community supports, or for current providers who are looking to see if we want to grow our program, what does that look like financially for us? Or if we, want to increase our caseload a little bit, what does that look like in terms of costs and benefits? So I think it's a really helpful tool. We're going to walk through a little bit of it right now, just to give you a taste of what it could do for you. And even if you aren't the budget person at your organization, I do think it's really approachable for those of us who are program folks. So next slide, please. So they have different tabs in this Excel spreadsheet for revenues, costs, and caseload numbers. They also have wonderful examples. So if you are a visual learner, you can walk through the examples to see how everything works. But the ECM and community supports revenue section, I think, is a really great place to start. So what we want to look at here is we're going to break it out by each of the programs here. We have the ECM. So you could plug in, if you're an ECM provider, what your ECM rate is. And if it's a PMPM or others, you could put that in here as well. How many people you're serving per month. And that would give you a sense of your revenue from ECM. Go to the next slide. We'll talk about community supports. Very similar. They have put in this example here, some of the standard rates for community supports. It may vary a little bit from what you guys have, but it does allow you to enter in what you're being paid per community support, how many folks you're serving or how many meals you're serving. So looking at all the different ways we can capture that revenue. Now, if we go to the next slide, it also captures some of these one-time revenue streams that you may have received. So if you received IPP or the incentive payment program dollars from partnership, you could enter those in here for the year for which you are spending them. If you got past cited dollars, you could also list them there. And then you may have gotten some other funding to help jumpstart your ECM or community supports, and you could enter those dollars in here as well. So these three sections would give you a total of what your revenue may look like based on your caseload for a given time period, a year or shorter if you're only working off a partial year budget. They also have a tab in the worksheet to enter in the cost for your program, and that would include things like staffing costs, if you had to buy tablets or phones for folks, or other costs you may have incurred to do your ECM or community support. So it captures all of that. I'm not going to do a visual for that because I think it is pretty self-explanatory. They do have a bunch of line items in there that may or may not match your budget, but you can adjust it as necessary. The key is we want to capture what your total revenues are, what your total costs are, to help establish what your ability to be financially sustainable is. So we go to our next slide. I love this part. They have taken all that information for revenues and costs, and they put it into this summary worksheet here in the worksheet. And it's really trying to establish what is your profit margin, which I know is not a term that we often use in our sector, but I think it's important to look at, are we financially viable? Can we sustain these programs we're using? And it can be used for year one, and you can build out for future years. So if you wanted to grow your program over the next year, you could look at what that might mean for your budget. And so it does take, if you look at the very top here, the profit margin at the top, that would tell you what percentage you would be earning there, and it would list out all the line items. And then at the bottom, it has the net income, and that would give you the dollar amount. So if we look at year one in this example, this organization would have a profit margin of 1% or of $1,300 for, let's just say, ECM for this year. And then as they grew their caseload and started to serve more members in year two, you can see that their profit margin would grow to 6%, let's say, and that would be an increase of $14,900 here. So I really encourage you all, if you are trying to figure out the budget for ECM and community supports, trying to figure out what it means for your organization's bottom line, I think this worksheet is a really great tool to use in helping you figure out the costs and revenues. Are there any questions on this very brief overview of the tool? We did put the link in the chat here so you can access it. It is an Excel spreadsheet you can download. It's very flexible, very adaptable, so you can modify it, especially on the cost side, to include whatever cost may be important for your budget. So I do encourage all of you to check this out. If you do have questions, please let us know. We also know that the Camden Coalition, who put this together, they have a contact person there too. So reach out if you want any assistance in walking through these worksheets.
I just have some general feedback. I think these tools are really helpful, like on the program side. And it can also, because there's always like additional things that you need for like patient success and just to know where you stand the sooner on. I think it's really helpful.
I agree. I think that's important. I love the piece about patient success. You may have additional costs that aren't captured in this worksheet that may be what you have incentives or things you may do for for your program. So being able to put those in will be important. Anybody else want to jump in here before we move on? All right. Next slide, please. So in addition to having this great budget tool, I also want to promote another tool, which I hope you all are aware of and maybe even using, which is the TA Marketplace. The state is really expanding the offerings, and they are trying to promote this being utilized by all of us here today. This is a free TA resource for all providers. And it is intended to help you implement as well as manage your ECM and community supports program. So I encourage all of you to look at it. They have just redone the website, so it's a little bit different. If you haven't been on for a couple months, it's a little bit different, but they have a lot of offerings up there. They have off the shelf, which is a more standardized TA that you can access. They also have hands-on, so if you have a unique situation or want help with a specific problem, you can hire a vendor through the TA Marketplace to help you with that. Additionally, they are having a vendor fair on Thursday to promote vendors that are serving domains 5 and 6, which is around health equity and cross-sector partnerships. So if you want to check out what vendors are in those domains, you can go on and hear what the vendors have to say on Thursday. I think it's at 9 o'clock. Next slide, please. So now we've covered the big the big policy updates and tools that we've seen come out across the state. I don't know if there's anybody here locally who has any updates they would like to share too. Oh, wait, I see a chat question about the TA Marketplace. Is there an easier way to access the TA Marketplace? We've been having a really difficult time even getting in. So I actually have found the website redesign to be a little challenging for me as well, even though I've spent a lot of time on the TA Marketplace website. One of the things I have found, and it's a little bit challenging to find, but they do have a step-by-step process of like step 1, if you want to be a TA recipient, you need to apply here and the link there. The biggest thing to do is to apply to be a recipient, and that shouldn't take too long to fill out, and it shouldn't take too long to be approved. And then the question becomes, who do you want to work with and for what TA services do you want to receive? And that's the part that can take a little bit more time. And I don't know if there's anybody on here who'd love to share an experience if they've successfully accessed TA through the Marketplace. So remember, if you do have questions and you'd like some, additional help, please let us know. I'm happy to help you walk through how to access the TA Marketplace. And Saad and I see your hands up as well.
Yeah, I was just wondering if Rima could describe some of the challenges she's had in accessing it, because I think there's been some conversations among facilitators. So would love to hear from Rima before I kind of give one piece of a response.
I can jump in because I work with Rima, and it's actually been me. And Visions of the Cross has been really helpful. They've given me some tips, and now I need to call them. So we are Path 1 recipients. We applied to get in, like we've done all of that sort of stuff. We followed it. What it's really come down to now is the authentication process that they require to get in. And then the password doesn't match the authenticator. And so then they send me a new link and I can get in like that one time. But when I go to put my password in, like as an ongoing user sort of thing, it doesn't work and it doesn't prompt the authenticator. And so I guess like my overall, and I understand like they want to protect their information. Like I really get that. And it's very tricky to have to, it doesn't make it user friendly. Like a lot of us are working in these like short time frames to be able to like go on and look. And if you have to dedicate 8 hours to like get into a website, like that's not my jam.
Yeah.
That's, you know,
that's anybody's jam, Amber.
Yeah, like that just doesn't feel helpful, you know, like by the time you actually, because I did get in, I went and I yelled at my team, like, I'm And then I went in to get it again, and it was like, you don't have your password and you have to reset it. And but it, yeah.
Yeah, and I see Carolyn giving a thumbs up. And I don't know if Christina wanted to say something on this point as well, but I'll kind of exit and give it back to Gretchen. Thanks for the voiceover, because something that we've talked about is like whether we should do like an office hours on the TA marketplace, and kind of whether that would help support folks getting on, or is it like further down the line? It sounds like you're having challenges further down the line. It is helpful for us to know about those challenges, because we can take it back to the TA marketplace while users are also doing that, but from a different route, and hopefully get kind of faster responses. But just wanted to learn the nature of the issue, and I think we can have like a troubleshooting strategy to help you guys get on more consistently without that tech headache, which understandably would keep anyone from trying to access these resources. Sorry, Gretchen, thanks for letting me jump in.
No, I appreciate it. And Amber, you're not alone. I've had authenticator issues as well. It's taken me weeks to get sorted out with PCG. So it's not just you.
Well, that helps, because I did, whenever it's tech related, I always just assume it's me initially. And then I was like, wait a minute, I know how to work TikTok. This isn't me.
You can work TikTok. You're
Yeah.
good. Yeah.
I did want to just share an update for those of us in the Northeast region. It'll primarily be our folks that, are close to are in Shasta County. But Project Homeless, that would be a great TikTok. It shouldn't be me who makes that, but yes. In Shasta County on May 20th, we're having our Project Homeless Connect event. That is a great community fair, for lack of a better word, for individuals who are homeless, where all service providers get together in one area. It's at the Civic Center. And they have like animal care providers. Sometimes they have individuals who are doing like haircuts. Like a lot of times probation or parole will be there. The Hope Van will be there. There might even be some ECM providers there, like signing people up. But for anyone who works with that target population, definitely want to have that on your radar, because that's like a really great place to do a lot of care coordination. So again, it's May 20th. It's at the Civic Center in Redding, California. And it's pretty much all day. Like it starts at 8. And we'll go, pretty close to like 4 or 5 o'clock.
That's great. Thank you for sharing that, Amber. Carolyn, I see you have your hand up as well. Do you want to jump in?
You and Amber, it's an update to the Project Homeless Connect. As of yesterday, we're being told by the Civic Center that we may be forced to change our date. So we are desperately battling to keep this date the same, since we are the organizers of that this year, as well as last year. So my colleague, Wendy Longwell, who is my systems change colleague here with the Disability Action Center, that is an event that we organize with our center every year. And unfortunately, there's been some discrepancies going on backdoor between the Civic Center and another party, which is affecting the dates. We are battling to hold the 20th as the date. They're trying to push us to the 13th. So if you would kind of pass that word around to have individuals, please connect with Wendy. But like I said, we're desperate. It's not easy to get connected with that cross-section of our community population. So changing the date could be really devastating for many who would be showing up, who have a one shot at transportation to getting these services. So I just wanted to toss that in there to make sure that everyone is aware. Please triple check. Please call the Civic Center and clamor and cry and shout that we need to keep that date, because they're trying to push us to a week earlier, which would be devastating.
Well, thank you, Carolyn, for that update. Yeah, I hadn't heard that yet. And we just talked about it at our department meeting today. So we'll definitely reach out to Wendy. You guys have done a great job coordinating that. So yeah.
Thanks, Amber. Yeah, spread the word and rally on the Civic Center. Sorry to like squirrel on that one, but I was like, oh no.
Yeah, no, thank you. That's helpful. That's helpful information. And we'll hold tight. You let us know if what day we're showing up.
Thank you, Carolyn. I'm gonna send good thoughts that it gets worked out. All right, anybody else have any updates to share?
I do. I have one tiny little thing that I need to share real quick. Hi, guys.
Oh, go, Christina, hi.
Sorry, I was a little bit late today, but I just, life. So I wanted to let you guys know we are part of Dignity Health, and I know there's a lot of rumbling about what's going on with the Dignity Health contract between us and partnership. And I just wanted to let you know that our ECM and community support side of it is no way impacted by this conversation. We have a separate contract for CalAIM services. So we are still providing like medically tailored meals, all of our respite services, and all of our ECM services still. That is not affected by the contract negotiations that are happening with partnership and Dignity. So if you guys have questions, I'm happy to answer whatever you need as much as I have the ability to, but wanted to let you guys know that that hopefully doesn't impact here.
So thank you for sharing, Christina. Do you want to put your email in the chat in case folks do have any questions about that? That'd be really helpful. All right, anybody else? Looking to see if we have any hands. All right. If not, can we go to the next slide, please?
So as always, we know that there is a ton of information and want to remind you as always that we're here to support, and we would love to have individual one-on-one conversations with you if you have any questions or are in need of certain resources. My email is there. Please feel free to reach out to us and we can schedule some time.
Great, thank you. All right, next slide, please. So there were so many great conversations at last month's CPI meeting, and we wanted to dig deeper into our referral coordination conversation and start to get some deeper conversations, think about things a little bit differently as we go forward. And so we wanted to start a series of conversations over the next few months about how do we work to strengthen and improve our ECM and community supports referrals. You can go to the next slide. And so I think as we talked about last month, we did, as of course, part of our job here is to create some goals and aim statements here for our work as a collaborative. This is what's required by the state. And so as we talked about last month, we did want to focus on coordination of referrals. So we have put in the goal that by December 31st, the Northeast CPI will have improved coordination of ECM and community supports referrals among local providers, as measured by local provider satisfaction. So we'll be working on that goal. Some of the drivers we've talked about, and I think this again came out of last month's conversation as well as previous months, CPIs is to look at how do we streamline provider referral pathways, how do we strengthen local relationships, how do we facilitate peer-to-peer support for local providers. I think looking at, again, beyond Shasta County, how do we expand provider capacity? How do we identify the learnings that have come already and share that broadly from Shasta out to the frontier counties, as well as amongst providers in Shasta County? So this is what we're going to be focusing on. This is kind of just the bit that we, the bigger framework that we're working. Are there any questions about these aims and measures that we're talking about today? Okay, great. Well, let's move into the fun stuff then. So to jumpstart our conversation today on referrals, we wanted to kind of get some brainstorming going amongst all of us about what have been your best ECM and community supports referral experiences. What's made those either good or bad? What was the impact on the clients of these particular experiences? And then what are you thinking about either how to replicate the good and how to adapt things so we don't have any more of those bad experiences? So again, just a brainstorming session. Nothing is going to be taken as, here's what we're working on now, but just trying to get some idea of what's working and what's not in your communities for these referrals. So I don't know if I have anybody who wants to be the first one to volunteer to share either a best referral experience or a worst referral experience, but if you are brave enough, I'd love to have you come off mute. And also if you can be on camera, that would be great too.
I'm happy to share some.
Thank you, Amber.
So for ECM, our best referrals are when we have like an existing relationship with the patient. So like they're a client already of the health center, or we know them from our street medicine program. We get a lot of really good referrals where like, we'll be working with one client and they'll refer a friend to us. So those are our best like engagement ones because we know where to find them. You know, they already are familiar with our services. And so it is really helpful.
Can I ask a quick question? Amber,
Yeah.
I'm sorry. So when you have clients refer a friend, do they actually bring the friend in with them, or how do you contact that friend? How do you start to build that relationship?
Often it's when we're out in encampments. So we have a street medicine program, and then our case managers also are frequently out in encampments because that's one of the populations that we serve. And so they're also out there. So a lot of times they'll like walk us over to that friend and we'll be able to reach out to them.
Okay, great.
On the flip side of that, what's also hardest about those is often they don't have partnership insurance. So like best referral engagement wise, and often tricky if they don't have partnership insurance, because then we have like strong engagement, but it may take like multiple months for them to get actually like complete the process to get insurance. For community supports, I would say, because we have a medical respite program in partnership with Pathways to Housing, and we get a bulk of those either from our Hope medical team and then also the hospital. So those ones like are really great because we already have everything we need to be able to like do a nice TAR on them. And like, you know, again, as long as they have partnership health plan insurance, then we're good to go.
Great. Thank you for sharing all those, Amber. Anybody else want to share some best or worst experiences for referrals? Okay, Christina, I saw you raise your hand.
I am one of those people that will keep you engaged this entire time. Just kidding.
Love it.
So some of the best ones that we've got is because we offer so many different community programs here at Connected Living, is a lot of the referrals that we get that are for other case management programs or something else that's going on in the center, where maybe we're full or we don't have grant funding for it or something else. Because a lot of the services we provide and the populations of focus that we serve all kind of are in alignment with each other. The best things that we have done has been able to actually serve additional people that we wouldn't have been able to otherwise through the grants that we have for the other programs. So some of the referrals that we get for MSSP, which is considered a duplicative program, we're at capacity for MSSP. So it makes it really easy for us when we get a bunch of people who are still being referred to us to get them involved in ECM and starting the case management engagement, because these are people who really need that longer term case management anyways. We're able to get them started on that process and building the relationships with the people here until they're ready to go on to MSSP or something else. So that's one of the ways that we have done that. We've built a lot of relationships inside of the community, and partially because of CPI actually, where we've been able to talk about who are the people that we're serving. Are we really focused on the right populations of focus? Because for us, we do not serve the homeless population as closely as someone like Amber's team would do. And so we've been really working hard to make sure that we are serving the right people. And if there's an opportunity for collaboration around somebody, then we are doing that. I will say the community sports side is probably where our worst referral experiences come from, because things like respite services oftentimes get confused with medical respite. And those two services are very, very different. So we've gotten a lot of referrals that are just not appropriate for just regular respite services. The personal care stuff that we have gotten are things that are way outside of our scope. So we haven't been able to do anything on those at all. And then I would say probably medically tailored meals is our biggest success story when it comes to our community supports, because we are local. We already run the Meals on Wheels program in the area and stuff like that. So we have a lot of good experience there, and people already know us about that. So I say MTM is probably our most successful of community supports, but the rest of the referrals that we get are not great.
Love it, Christina. Thank you for sharing. I'm actually going to call on you in a couple slides. I think you actually have some great insight to share, and I'd love to ask you some more pointed questions when we get there. So I'm going to keep you on the hot seat. Anybody else want to share some best or worst referral experiences today? Do you guys find that there are certain services, like Christina mentioned, medically tailored meals, that are easier to refer into or get referrals for than other services?
I will say also with the personal care and respite services, for the most part, we are providing those in center because we are staffed and built up to be able to provide those in center, and we are not staffed to be able to provide that in people's homes. And so because there's that liberty of being able to do it what works best for your organization in order to get people contracted and whatever else, you end up running into a lot of different confusion or problems, I would say, with the referrals that are getting sent, because there is no delineation on partnership's website that says this is what they can do.
No, that's a really good point. Okay, so these are all good things to think about. All right, anybody else want to share experiences here? All right, so then I'm going to jump a little bit further. So we've heard some examples of best and worst experiences. And so now I want to think about how your organization or your team is thinking about how do we try to replicate the best experiences we've had, and how do we try to adapt the worst case referrals that we've had. And I was curious to learn more about how you and your organization are thinking about how to do that. Are you setting up data collection processes or practices to try to collect data around different types of referrals? It could even be that when you get your MIF every month from partnership, how many of those folks that you call, how many of those actually answer the phone, and how many do accept ECM enrollment? So that could be something that you could be thinking about. What does it take to actually enroll folks off of the MIF? If you're getting community referrals, what does that look like? What is the effort put in behind that? How many engagement attempts do you need to have to engage folks? Or if you have someone refer their friend over, like Amber mentioned, what does that look like in terms of efforts? Are you guys doing any kind of team conferencing or meeting to discuss what's working, what's not? Thinking about what are the roadblocks we're encountering? How do we start to address those roadblocks? I know a lot of organizations are just starting that process. And then, of course, our favorite thing we want to think about is tests of change. Are you guys running any tests of change to see how do we make small changes that could lead to improvements in referrals? We all know about the PDSA. We've talked about them in our CPIs before. You love them, I know. But you also may be doing other tests of change. You may be doing some mapping. You may be doing some other things to look at how do we adapt things to make them work better. I see, Amber, you have your hand up, so I'll call on you. And if there's anybody else who wants to jump in, please raise your hand as well.
Yeah, so we just actually, because we started to have a decline in our referrals, we noticed like the past 6 months, we saw them going down. Our caseload side's going down, not so much referrals. So we've been really looking at like how many are we screening to how many get engaged, and then like how many sign up. Like so from screening, they're appropriate, and this is specific to ECM, and then they go, they get assigned, and then from that, like how many actually engage. And it's a pretty heavy workload of screening to engagement for success. So like we're finding we'll get like on our MIF, we'll get about 80 people that are appropriate. But from that 80, we can only get 17 that are interested in like moving forward. So like, so we'll like a lot of them, you know, they don't have, they've moved, they don't have good contact insurance, maybe they've lost their partnership, like it's no longer a need for them, like whatever they, you know, were approach, you know, that they were interested. So we'll take 80 referrals, we'll screen them, we'll get 17 that is like, okay, they could be good. And of those 17, only like 2 to 4 are engaging. So we've been really kind of paying attention to that. And one of the things we're doing right now for our test of change is trying to see if we can increase our engagement with our outreach process. So our folks that we find on when we're doing outreach in the encampments, are we able to like, so whoever meets them in the camp, they're getting automatically assigned to them. We're doing more like targeted outreach. So we've been playing around with that.
That's great. Thank you for sharing that. I like how you're segmenting different parts of the engagement process so you can see where there may be gaps. Then Amber, quick question on how you're collecting data. Are you using an Excel spreadsheet? Is it part of your case management system? How are you actually collecting and organizing the data?
So my Rima, who does the direct supervision, she keeps a spreadsheet of all the assignments. So she's been looking at caseload sizes. And then we really work off of the MIF to the IoT and the RTF. Like we're really kind of trying to use those tools that we already have available to us, but also been looking at, so we're looking at, is partnership a better referral source for us or internal? So we have reports that we can run internally off of our electronic health record.
Oh, I love it. Great. I like that you're using Excel too. It's not super complicated. So that's really helpful too. What are other folks doing to look at what's working? How do we replicate what's working, what's not working? How do we identify those? You have a 5% enrollment rate from your referrals. That's from the MIF, or is that from other referral sources?
All of them.
All of them. Okay. Have you separated out the different referral sources as to what yields more clients?
No, not necessarily. Our biggest referral source from the get-go was definitely the MIFs, right? But then we've also been seeing that our MIF numbers have been going down. And so we really started to push hard to find new referral sources. And so, you know, one of our populations of focus is readmissions at the hospital. So really engaging over at the hospital to be like, hey guys, this is here for you. Like, let's work together on this. And so they have been pretty good about sending us some referrals, but our engagement rate is still about the same. I would say our engagement rate is higher if we're able to engage them while they're still in the hospital, but it isn't still not always super successful because they're like, who are you? Why are you here? I'm sick. I don't want, you know, so sometimes it's a win, sometimes it's not. And then also I just don't like staff just sitting around at the hospital waiting for the next potential person. So we're still refining some of our practices on that. But that's our biggest referral source right now, because the MIF has been getting so small for us. And I would say we're also working on this big project right now about putting everything into Salesforce for our referrals and for other things to kind of get more data collection and just be a little more savvy with the information that we have for all of the programs here. We're still in the development stages, so we haven't implemented that yet, but we're really excited about that test of change.
I'm going to check in with you in a little bit and see how Salesforce is working, if it's giving you some more information. Are other folks seeing their MIF decrease? The numbers on the MIFs decrease? Anybody else want to share what they're doing to try to either track what's working or what's not? Any tests of change or PDSAs your team is running? All right, well, if no one is willing to jump in here, we're going to move to our next slide, which is going to be a poll, and so thinking about where our referral sources come from, I wanted to first start out with what populations of focus you all here today are serving for ECM. So we want to launch a poll that will have you identify all the ones that you're serving, so we can just get a sense of where our providers are today. Which populations of focus do you serve? And you can list all that you serve. All right, I'm watching all the numbers come in. And we'll give it about, I don't know, 15, 20 more seconds, and then we'll close the poll. All right, let's go ahead and close it. We can share the results. I'm excited to see that there's every population of focus being served. The birth equity, I saw that the one provider came in a little bit late, but I'm glad to see that all populations of focus are being served. It looks like, yeah, it's really, you guys do a great job here. Okay, so we do see some of the children and youth, which are relatively new populations of focus. We don't have as many providers for those populations, adult nursing facility residents. Okay, all these are, yeah, individuals transitioning from incarceration. Okay, these are all good to know. So I'm going to stop sharing the results and we're going to go to the next slide. So now that we've identified what populations of focus that we are all serving, which is all, I want to see, are there referral sources that we can start to think about either engaging for the first time that are serving these populations that we're also serving, or are there referral sources that are being underutilized? We want to really ramp up, and I know sometimes these are the ones that I think about often in the communities I work in. Are we fully utilizing the hospital? I know, Christina, you mentioned that sometimes those are good referral sources, sometimes they're not. It's hard to capture all the discharge planners to train them on how to do ECM and community sports referrals. So we know that is one source. Maybe we're not fully utilizing that. We can talk about that. There may be clinics. I don't know how many of you get referrals from clinics for ECM or community sports referrals. Are we fully utilizing them to make those referrals? Do we have any homeless shelters that folks work with where they get referrals for ECM or community supports? Okay, and then I'm going to talk about your organization. Are you guys screening the folks you work with for ECM and community supports? And if you don't offer, let's just say you're an ECM provider and don't offer community supports, are you screening for community supports and then making referrals out to your other providers here in the community? How many of you guys do that? Just want to raise your hand. Okay, some of you guys do that. Okay. I think this is an exciting thing to think about. How do we do this? How do we make sure that we're really assessing what a person's complete need is and how do we best serve that individual? We may do it all ourselves. We may be able to refer out. So thinking about that. I know, Amber, you had mentioned street medicine, and we're actually going to have our street medicine team from Shasta come out and talk to us next month in our CPI meeting, but looking at what is their role in this continuum of care? What role do they play for ECM and community supports? And so thinking about how do we access those providers who are in the encampments, who are working with certain communities, how do we access them to make referrals, to engage members, to get their needs met? So thinking about that as well. Where else could we think about trying to engage referral partners that are either not being fully utilized as referral partners or that we need to think about engaging for the first time?
Skilled nursing facilities.
Skilled nursing facilities, okay. What would that look like, Christina, in your mind? How would we engage them?
So one thing in this area for sure, our skilled nursing facilities are impacted a lot. And I would say a lot of people who are in a SNF that are transitioning into community, that's already a population of focus, or they're at risk of going into long-term care, which is the other population of focus. And so a lot of people who are in a SNF already, if they want to see people get transitioned out of that, that's one of the things that ECM can help with. And it can help alongside some of the other community supports that you provide too. So it seems like a skilled nursing facility, since you have a lot of people who transition there out of a hospital, they need to know a little bit more about what we do and how we do that. It could just be simple presentations that we do over at the skilled nursing facilities, but that only goes so far. So I think there just needs to be another strategy there that I don't know if I've identified yet.
Okay, thank you for sharing, Christina. I think SNFs are good. Amber?
Yeah, I think if you're doing the SNF reach out, it'd probably be really good to also partner with adult protective services. And, you know, some of those folks, like that's going to get you into the housing game too. So because if, you know, if they're in the SNF because they don't have a safe place to discharge, so like those would be the other areas I'd look at with that. Do we have folks on the call who are from frontier counties? So like is Modoc, Trinity, Lassen? Do we have any of those counties on the call right now? Siskiyou?
Hey, Amber, it's Shannon Garrick at Mountain Valley. So I am here on the call and I'm sorry, I'm not real skilled in this area. So just learning. We are trying to launch ECM. And so we would be in Siskiyou County, Lassen County, kind of the north west corner of Lassen County, potentially could touch Modoc County with our proximity to the Tule Lake Clinic and the Big Valley location, and then in Shasta County.
Awesome. Yeah, no, Shannon, I know you guys were getting going with it, which I think is super cool. I think the reason why I asked specifically, because like referral coordination in frontier counties, and please correct me if I'm wrong, Shannon, but like you're not going to have all, like this could easily be Shasta, right? But like in Tule Lake, you're not going to have access to all of these things. And so I'm just like, I think when we're talking about like this group, like what Christina and I have available to us and like other folks in Shasta County have available to us, it just like looks different, I would imagine, for you guys, right?
Yeah, for sure. So I think part of our going through this process is to really see where we can develop some, maybe some supports along the way, because ours will be different. It'll be like churches and community centers as opposed to, and schools probably, you know, a lot of really small schools. And there's a lot of, we've been trying to figure out how to kind of bridge. We currently go into one of the schools in our service area, and we just started going in there for like case management and just kind of behavioral support. And we have a case manager who has 14 students. So trying to figure out how to incorporate the student population into ECM because they have a lot of needs because of their family situation. So anyway, gonna learn more on that, hopefully from one of you experts.
Yeah, and like some of those kiddos may have parents who meet some of those other populations, and like, you know, everyone knows like when you're working with kids, it's often the parents that need the intervention, and like the kids that get to be like the byproduct of that like good work. So but
yes, exactly.
My only other thing that I was going to share, and I know other folks have their hand up, but like in my dream world, and I don't know how you would do this like in our region, because it may or may not work, but like Christina, you're in an awesome spot where, because you do work with a lot of different counties, like it may work to do it regionally. But if we could have like, even if it was quarterly, some sort of local ECM meeting. So like Christina, you're getting med respite referrals instead of like personal respite care. Like that would be a great, like if locally we could be like, oh, here's other places that do med respite, so I'm just gonna like hand those off, right? And I'm not equipped with working with the SNF population. Like sure, we do it, but it's duct tape and baling wire, so I'm handed off over there. And you know, Disability Action Center, like they're better at this. And so if we could figure out a way to maximize you know, and obviously share it safely and keep everyone's information protected and like all of the things. But if we could figure out a way, and maybe if it's regional, like where we're also like providing support to those counties that don't maybe have as much access to services, but that would be great to be able to match, because like you saw, there's like in the top 3 populations, there's like 80% of us all serving that population. And so then it gets tricky about how we're not competing, but we're collaborating.
Thank you guys for sharing. Lots of great information. Aretta, you're going to be my last comment, as I know we're kind of getting short on time here, but Aretta, if you want to come off mute and share, that'd be great.
Hi, good afternoon.
Yeah,
So
what
I
is
was
it?
just thinking, the only thing in terms of I oftentimes think of like the county, you know, where people get food stamps and cashade. I always thought that would be a nice area to pick people up from, if I said that correctly, but to coordinate with some of those members.
I love that idea.
Yeah, thank you.
Awesome. Oh, I love all this. Okay, great things. Thank you all for sharing. I'm actually gonna quickly go to the next slide just to kind of give you what I was thinking about. We may cover this at a future session, but looking at where our information gaps are with our referral partners, what information do people need to have? I think Christina, you mentioned they need to be trained on what ECM and community supports is, who's eligible. So thinking about where those gaps may be, we'll talk about this a little bit later. But before we end, I do want to have one last poll. So I want to get your ideas of where we can start to head as we go through this. So if we're looking at how do we strengthen and improve our referral coordination, what is our first step? Is that going to be looking at doing a provider directory with people's populations of focus and contact information? Is this doing referral partner trainings to make sure everybody knows what these services are and who qualifies? Is this developing intake questions that we can share broadly with our partner organizations and with our own teams about how to identify who may benefit from ECM and community supports? Are there other ideas we're missing here? And you're not really sure, we need to have more conversations, which I recognize we've been kind of pushing through this today. 20 more seconds. All right, why don't we share the poll results? It looks like one of the first things we can look at doing is doing some of the provider directory with contact information. So that's really helpful to know, maybe some intake questions, and we need to have some more conversations to really dig deeper into what would be a good first step. So thank you all very much. This has been such an exciting conversation. I hope we'll be doing more of this around referrals. We can really try to strengthen our system here, both in the Shasta County as well as the frontier counties. And Shannon, I look forward to hearing more about your journey as you go into ECM and the things you're learning. So we'll look forward to hearing an update in future months. Next slide, please. Abe, I'll turn it over to you here.
Great, thank you. So we just have one poll just to see what was the most valuable part of today's session. That just helps us make sure that we're continuing to provide content and agenda items that are exactly what's helpful for you all. I will leave that up for just a second, and we can go to the next slide. Our May meeting will take place on the 21st. That registration link and calendar invite will be shared shortly after this session. As I mentioned, please, feel free to reach out to us for any one-on-one support. And then we have office hours right now. I'm putting the link in the chat. So if you're available right after this session, hop on over to that other link and we'll be there if you have any questions or want to spend some more time continuing the discussion from today. And we can go to the next slide. We just want to thank everyone for your engagement today. We'll make sure that you receive all of the content information after the session and hope to see you in office hours. Thanks, everyone.